everybody should be seeing my screen right now. So obviously, DeVero, as well as everybody else, is concerned with some of the things that goes on in the industry that most affect the people who are working every day, whether it be in the offices or in the field, seeing the patients. We know that you strive every day to do a great job of taking care of your patients, and that I'm sure that happens. Unfortunately, though, CMS doesn't call the patients to say how good a care did they give. It all goes by what you are documenting. So that's some of the things that we're going to talk about today. And then, ADRs, additional documentation requests, or just seems to be the norm these days, that you can't, no agency is immune to them. Everybody gets them for one reason or another, whether they be those that are probe, that they're looking for something in specific, or if they're focused, meaning that they're looking just at your particular agency. Everybody gets them. So that's kind of what we're going to focus on. Now, we know that we have people from all over the country that's joining us today. So what I did is I went to the three top payers, intermediaries, to see what it is that they are denying for. And you'll see, as we go through these next three slides, you'll see a lot of similarity here. All right. So, but look at number one in the CGS area. So those of you that are at CGS, you know who you are. But top denial in just January of March to this year. So we're only talking 3 months. All right. Skilled nursing services were not medically necessary. So 125 claims for 23% of all the claims that were submitted. All right. So, and we know that that's probably not the case. We go out there to see patients, and obviously we are going out there for a particular reason. But remember, when CGS or whoever your intermediary is audits this chart, they're looking to see what is documented. So, every nurse, and I'm sure every therapist also, learned one of the first things when they went to school was, if you didn't chart it, you didn't do it. So I don't care how much detail it took you to do that wound care that day. If it's not documented, then that means that your care was not reasonable and necessary. So this is how they look at this. All right, number two was the physician certification was invalid. So that's the story for a totally different webinar, an entire webinar. In fact, I'm sure that many of you have joined about face-to-face. But because it says the certification was invalid because the face-to-face encounter was missing, incomplete, or timely. That could have been any number of things. The date maybe wasn't there. The signature wasn't there. The homebound status was not accurate. But again, 110 claims for 20%. Requested documentation not received or not received timely. Now, this number always really just kind of flabbergasted me, because 97. So that means that you got an ADR, an additional documentation request, and either you didn't respond to it or you responded to it late. And if you responded to it late, that's just like you didn't respond to it at all. The documentation did not show that therapy services were reasonable and necessary. I can tell you, and we'll talk some about in a little bit later about why that is. Because we know usually if you send a therapist out there, it's reasonable, the reason that you're sending them, but it's not being documented. So we will talk about this. And then initial certification was missing, because remember, if you get an ADR, say, and that particular episode was a research, you have to send in the original certification where they can look at the face-to-face documentation. So that's just CGS, all right? Palmetto. All right, so those of you that are in Palmetto know who you are, and you can see their claim, their number of claims, it's much, much bigger. But look at what's number one in their list from January to March. Auto denial because requested records were not submitted. Now, they don't write it the same way, but they're either not submitted or they were not submitted in a timely fashion. That number, again, is just, it is unreasonable to think that many people are not. But I think in some cases, what I've heard somebody maybe jokingly say, maybe not so, that maybe agencies look at it and they go through their records and they think there's no way this is going to pass, so they just don't bother to send it in. But remember, those numbers count against your overall denial rate, so you still need to send this in. And of those they sent in, 18% was because the face-to-face requirements were not met. So you'll notice that the different intermediaries write it differently, but it's the same thing, that something in that face-to-face encounter was not there. Homebound status maybe, the date was not there or something, all right? HIPS code changed due to partial denial of therapy, all right? 10%, that's a lot, because that means that a big part of your HIPS code is based on how many therapy visits you're going to have. But when they start looking through the entire chart, then they say, well, then there's some reason that they're doubting whether these therapy visits were even necessary. No plan of care or certification. So not a big number, but that should never be. We cannot see a patient without a plan of care, nor without a certification. So it could be something simple like it wasn't signed. If it wasn't signed, then as far as they're concerned, it's not there. All right, so, but we'll talk more about it, the different one. Info provided does not support the medical necessity for therapy services. Unable to determine medical necessity of the HIPS code bill as the applicable OASIS was not submitted. So it's not in the system, all right? And then finally for NGS. Now I didn't have percentages for NGS, but I did get the top 5 reasons. Documentation submitted does not support homebound status. We'll talk about what that is. Medical necessity not supported as the OASIS was not submitted. Skill observation was not needed for start of care. And I can tell you that that's a big one, because you're seeing this patient research after research after research, and it's not supporting why you're still out there. Skilled nursing services were not medically necessary, and this may be like from the very beginning that they weren't necessary. Requested documentation not received timely. So that means you may have gotten an ADR, but you did not respond to it in time, all right? So we want to make sure that everybody understand that why they're getting. So if you are in one of these areas and you may want, and you're not sure, because I can tell you it's very important for you to know why your records are being denied. So let's look at some of those specifically. All right, so medical review HIPS code change documentation contradicts the M items. That just means that the OASIS data conflicted with what was billed. All right, so what happens sometimes is that you originally submit an OASIS that has a HIPS code on it, all right, and then at the end you bill for something that's totally different. Now, I can tell you one of the primary reasons that this happens, and I just talked to a huge agency this week who said that they never do other follow-up assessments, which is reason for assessment number 5. A lot of you, if you've been in the business long enough, know that that means significant. It used to mean significant change in condition. All right. So I'm going to give you an example. Your patient had nursing ordered from the beginning. Nursing has been seeing the patient. Patient did not need therapy at all. Was actually pretty independent functionally. But 3 weeks later, patient falls, bruises their hip. Now the doctor says, okay, we need to get therapy out there for safety and maybe to get them walking better. And then you put therapy in. So when you bill at the end, you're going to be billing for that therapy, right? The problem is your OASIS that you submitted in the beginning had nothing on it about why that patient needed. So you need to make sure, again, that may be a story for a different day, but if you are going to add a service, or if your HIPS code is going to somehow change because of what you're doing in the middle of an episode, remember you need to do an other follow-up assessment. All right, more, these two are pretty much the same, but more visits that were reasonable and necessary. So in this case, usually it's skilled nursing. Visits are not covered because documentation indicated more visits were provided than what was reasonable and necessary. Here's one of the things that you need to understand, that even if you project that a patient is going to need 3 visits per week for the whole episode, you are under no obligation to do that. If a patient gets better and their goals are met at 7 weeks, then you are expected to discharge that patient, because every visit note should stand alone. Now, when you submit your final claim, does anybody look at that? No, they really don't, because they don't see it. But if that chart gets audited as in an ADR, they're going to go through every visit note, all right? So in this particular case, visits may be denied. Now, they may not affect your payment, but they will affect your overall denial rate. Because again, each visit note for all disciplines, whether it be nursing, PT, aid, whatever, has to stand alone. So again, maybe after visit 13, you're indicating that patient understands everything they're supposed to do, will be doing. Their incision is healed. It's looking good. Patient is ambulatory, but you continue to see them for 2 more weeks. Well, this is what happens here, because they're going to say those last 2 weeks of visits were not reasonable and necessary. Now, in most cases, that will not affect your payment. But again, like I said, it will affect your overall denial rate. But imagine if you only had 6 visits scheduled, and then they decide that the last 2 were not reasonable and necessary, then now you are going from a regular episode to a LUPA. So it very well could affect your payment in that case. No plan of care or certification. So there's none established and approved by a physician. And again, it's hard to believe that that doesn't happen. I'm quite sure everybody does it. Or maybe you just didn't turn it in. So it means that when they ADR that charge, you didn't turn it in. But all pages must be included. All right, care plans are omitted from the ADRs, or maybe the wrong plan of care was submitted because agencies are working against a deadline, especially if you got 5 at the same time. And they even consider that when it's not signed and dated, then it's not there, because that means that it's not valid if that's the case. So as we talk about at the end about QAing this, we're going to talk a lot about how you can avoid these things. Unable to determine medical necessity of HIPS codes billed as appropriate OASIS not submitted. So these numbers I'm talking about here and the reasons, these are just the top denial reasons for anybody. Those first 3 were just for the 3 different intermediaries, but this is for everybody. So here, home health did not submit the OASIS for the HIPS code billed on the claim. All right, so again, this a lot of time has to do when you add a service, you add a discipline, or something else happens in the middle of an episode, like a patient develops a wound in the middle of an episode, all right? Because that means you may have an OASIS, but you have a separate HIPS, a different HIPS code that you're billing on the claim, all right? Or the OASIS was not submitted for the ADR. Remember, when you bill, some people seem to think that when they bill for a RAP, they are submitting the OASIS. It is in the repository, but that's not really what they're looking at. So when if you get an ADR, you must submit the entire OASIS, all right? And meaning every page. So if you happen to send in the OASIS, but you missed the last page or the first page or whatever, then they consider that as not having been submitted. So make sure. And again, we will talk about responding to the ADRs, all right? Physician's plan of care and or certification present, but it's signed, but it's not dated. Very, very important, all right? Documentation submitted did not include the physician signed certification or the recertification. Electronic signatures ensure compliance with this standard. All pages are not of the plan of care are not signed. Now, if you know, it's okay that if your plan of care says page 1 of 8, that he signs that 1 page, all right? But if that's not clear that this is 1 of 3 pages and he only signs 1, then it's going to be considered unsigned. Info provided does not support medical necessity for therapy services. So I'm going to give you Jennifer's spiel on this. I mean, there are very clear reasons why this would happen, and it's usually that clinical documentation does not support the medical necessity of the skilled services from the start of care. All right? So why does that happen? Why does that happen? For those, everybody knows that when therapy is ordered, if it is a therapy-only case, OASIS allows, or CMS allows, for the therapist to open up their own cases. Agencies, though, can say, no, we don't want our therapist to open a case. We want nursing to open up all the cases, which is okay. That as long as, if it's in a therapy-only case, as long as nursing goes on the exact same day as the therapist. So usually the reason that this happens, though, that clinical documentation does not support the therapy services is in a case where nursing goes out, let's say on a Monday, and she does the entire OASIS, including the functional questions, which are the M1800 questions. She fills that out, and that afternoon therapy goes in to do his evaluation, and therapy did a great job. His evaluation was on point, and he says, based on what I see right now, this patient is going to need 16 therapy visits. All right, so that's the number that goes in M2200, and that completes your HERC score. The problem is the functional score, which is the total of the M1800 questions, was an F1. F1 pretty much means your patient is pretty much independent. So that doesn't support those 16 therapy visits that the therapist is asking for. Now, some people would say, well, I can't, what can I do? I can't let the therapist answer those questions, and you can't, because only one clinician can answer the OASIS. But what should be happening is, once the nurse sees that patient in the morning, she waits until the therapist does the therapy evaluation, and they have a conversation as to what that the two of them can agree on. All right. Now that happens whether this is a therapy only case and the nursing is doing the assessment, but it also applies when you have a nursing and therapy case. Nursing goes in one day, therapy goes in a couple of days later. If the responses on those functional moves do not support the need for the number of therapy visits that therapist is asking for, then you're going to have a problem with that. So you want to make sure that the two of them match. Now, there is no magic number, in case somebody asks, because people ask me that all the time. If I have an F2, how many therapy visits? If I have an F3, how many therapy visits? There is no magical number. But one thing I will tell you, that if you have an F1 and your therapist is asking for 18 therapy visits, then that's the problem. Because think about what an F1 is that patient is pretty much independent. Okay? So make sure you're looking at that. Also, the therapy evaluation must be complete, because that has to be a big part, because that's really what's going to support it. Now, unfortunately, in the beginning, when you're submitting this, you do not, they don't see the therapy evaluation unless they ADR that chart, but it still has to be complete. You may need to make sure that all therapy complying with the coverage determinations, and all your therapists know where that is. Again, ensure that the number of visits that the therapist is asking for is supported by what is on the OASIS. And when I say supported by what's on the OASIS, I'm primarily talking about those functional questions. But sometimes it has to do with what one of the diagnoses is. You know, if you have diagnoses, and again, a question that's asked often is, what is my therapy diagnosis? There are no such thing as therapy diagnoses, but there are definitely therapy diagnoses that support the need for therapy, such as gait abnormality, muscle weakness, you know, that history of falls, those kinds of things. But there is not a tried and true diagnosis that's going to say it's okay now for you to have therapy. So this is what I just talked about. Consider who's doing the OASIS in skilled nursing and therapy cases. So whether this is a skilled nurse case and therapy is also going to be in there, what the therapist is asking for has to be supported by what the nurse said. And if it is your policy that nursing opens up all the therapy cases, then again, you have to be sure that all of that is matching. Face-to-face encounter requirements not met. Man, everybody by now probably has gotten, unless you don't have a lot of Medicare patients, you have gotten your 5, at least the first round of the probe and educate. And a great number of those, I've heard it in the first round, up to 80% did not pass that first round. So a lot of people around the country are already in their second round of probe and educate. Meaning that they're asking for 5 records, and the primary thing that they're looking for is to see if the face-to-face encounter requirements were met. But one thing I want to caution you about, if you're submitting for that particular reason, and when you get the ADR, it will be clear that that's what that's about. remember, when you send that in, you open your chart up to every scrutiny that they have. They can throw anything at it. They can deny it for any other reason, even if your face-to-face encounter was met. So in this particular case, they're saying that the face-to-face documentation was not submitted with the ADR. And this is especially when the ADR that you got was for a research. So meaning that there had to have been an initial episode somewhere. If the ADR that you got was for an ADR, for a research, then you have to send in the original episode where the face-to-face was done. So that's one of the primary reasons why people are not meeting these. Homebound status is not adequate. We're going to go over some of that. The reason for skilled services was not adequate. When a doctor just says that he's referring this patient to home care for diabetes, that's not adequate anymore. Clinical data was not found in patients' acute, post-acute records. Again, you're going to have to be very specific on that. And as we move along, we'll talk a little bit more about what needs to be there. Info provided does not support medical necessity for this service. So this one is pretty simple, but it's kind of broad, and it's a lot of things that can be contained in here. But clinical documentation submitted for review did not support the medical necessity of the skilled services billed. So, maybe you have the fact that the patient is a diabetic and she has CHF and she has COPD, and yet you've got 10 therapy visits. So some of these kind of overlap, but if those are the 3 diagnoses I have and I have nothing else, like the patient has muscle weakness, or the patient is at risk for falls, or a patient maybe has back pain. I'm not saying you have to have that on every chart of a patient that has therapy, but that means that nothing that you did have supported why you bill for all of those therapy visits. And if you are ever wondering, how do I know exactly what medical necessity is for the different services, then go to the Medicare Benefit Policy Manual, Chapter 7, Sections 40, and for every discipline, the aides, the OTAs, the speech therapists, nurses, everybody, there is a specific section there that tells you what is considered skill for each of those disciplines. All right. Auto deny, requested records not submitted. So, I'm not sure, I don't know that I can offer any condolences, because that just means they weren't done. Now, let me just say this. So this means that medical records were not received in response to an ADR in the requested time frame. Therefore, they have been unable to determine medical necessity. So in that case, 21.5% of claims was denied in the first part of this year. All right. So you need to make sure that you have a means of tracking this. So when you're sending in, and I'm not talking about submitting your OASIS initially. I'm talking about when you had an ADR. You need to make sure that every one of them are sent with signed receipt requested, so that you can say, nope, here it is. This is the day that it got there, and this is the person who signed for it, because they do make mistakes. So, but if you just choose not to, which again, I know that there are agencies who say, I reviewed this chart after I got the ADR, and it is so bad that there's no way they're going to pay it anyway, and they don't send it. Remember that that's an automatic denial, and that does count against your overall claims denial, and you don't want that to happen. All right. So with all of these reasons there, what should be your focus? Well, first of all, administratively, review your claims through the direct data entry system or whatever other revenue management tool you have. Some of your software packages will track this for you and alert you when you have a chart that is in ADR status, and that status is going to be SB6001. All right. I just want to mention this because I just was talking about this to someone last week. Some of you will see that something is in ADR status and it has SB6000, and then in a couple of days it changes to a 1 without you having done anything. So sometimes that happens. It's only when you have it in this status is it actually requesting you to send in additional documentation. But you have to have someone who is responsible for this. It can't just be whoever happens to be the first one in the office that day. The thing that makes the most sense is that maybe your billing person, because your billing person is in your DDE system every day for some reason or another. Some people say, well, what about the letter that we're going to get? Well, I have to tell you that I hear some people get letters and some people don't. Sometimes it shows up into DDE and you don't get a letter for 2 weeks. And you only have 30 days in which to respond. So you want to get it as soon as. And if you send that claim in today, and if it's an automatic, if it's a focus audit or probe audit, chances are it's going to show up today or tomorrow in SB 6001 because it's an automatic thing. All right. But somebody in your office needs to know they are responsible for finding out which ones are in ADR status and letting the clinical manager or the DON or the administrator, however, but you need to know what your focus is and what your process is. Have a process in place to review end of episode so they will be clean for billing. So QAing 100% of your charts is probably a moot point for most of you that you can't do it. I mean, unless you have just a really small census. But you need to have a process in place to at least review end of episodes before you start to bill them. Make sure that everything is there. Because once you put it in for that end of episode, then it's done. And whether you figure out that there's something you missed, it's automatically going to go. And if it's something that they're focusing on, it's going to go into, or probing on, it's going to go into ADR status and you can't take it back. You can't say, well, can you take this ADR back and let me send you the right information? It has to go through the process. Review and discuss your utilization data, between it with your QA staff, what it is that they're looking for. And this is something, again, that I just encountered last week with an agency that their numbers, they're trying to figure out how to get their numbers up with meds and heart failure issues on the star rating and those process items. And it was probably the easiest fix that I probably could have discovered is that they truly have therapy only cases, and therapy opens all of their cases and closes all of their own cases. But in all of the cases, the therapists were answering no to the medication education question and the heart failure issues, because they said, well, that's not what we're in there for. So they were just answering no. For instance, the medication question that just says, has the patient and or the family been, educated on, the medication issues? Your answers are very simple. They're either yes, no, or patient is not on any medicines. And we know that doesn't happen very often. So in almost 100% of these cases, the therapist, when it was a therapy-only case, was answering no because they thought that they weren't required to do that. So I expect that when they look at their numbers again, they're going to get better. So look at that and see how it is that you're answering those questions. That's one of the things that you should be focusing on. All right. Mandatory multidisciplinary case conferences before recertification. Everybody needs to know, why is it that we're recertifying this patient? We know that we shouldn't be recertifying patients just because patient doesn't have someone else to take care of them, just because the doctor says, well, now, you know what, continue to do teaching. But, we're in a third recert, or we're going into a third recert, and we're still saying that the primary reason that we're out there is for education. Well, we have to be very careful about that. So everybody has to be on the same page. Maybe that patient does need to be recerted, but everybody has to be on the same page as to why we're doing it. Not simply because patient expects it, or what the answer that I get a lot, that if we take the nurse out, we have to take the aide out, and she doesn't have anybody to give her a bath. So we need to make sure that we're looking at why it is that we're recerting, and everybody has to agree. Provide education during orientation and annually on the coverage guidelines. So all of your clinicians need to know what is expected of a patient before we recert them, or before when we get to the point that we think that it's time for us to discharge this. Look for late paperwork. Notes that are completed long after the visit are very rarely accurate. There's a really good study that I read once that said that if you do your paperwork while you're in the patient's home, then you're going to have a pretty good accuracy rate. If you wait till you get to your car, it drops maybe 10% or so. If you wait until you say get to McDonald's and can order you lunch and sit in the car in McDonald's parking lot and do it, then it's going to drop another 10% or so. And certainly if you wait till you get home, it's when your kids are all over the place, your husband's asking you questions, the TV's on, it's going to drop a lot. And most certainly if you're one of those that waits till the end of the week, on the weekend when you're at home and you think you got time and I'm going to do 5 patients OASIS, then the accuracy is very rarely going to be accurate. So you want to make sure that nurses know agencies should have a set policy that says from the day that you do the OASIS or from the date of the Mu-90 date, you have 48 hours or whatever it is that you choose. Nurses have 5 days to do their OASIS. So if you give them that 5 days, well, I shouldn't say 5 days to do their OASIS. They have 5 days in which they can make corrections to the OASIS. But if you give them that 5 days and then you're looking at another week before they turn in the paperwork, my question would be, if it was finished 5 days ago, why are you just now turning the paperwork in? So you need to have a policy. Review medications in the computer to look for clues for incorrect or incomplete diagnosis coding. So, we know we can't diagnose or we can't assign codes based on medication, but we need to know what it is, some clues as to if this patient is on this medicine, but they're not, I don't see a diagnosis that coincides. Let's see what this medicine is for, or is it being used off formulary. All right, so who's looking at your documentation? All right, because there's a lot of people that's looking at it. All right, besides the people in your office who should be looking at it, but you have RAC, which is Recovery Audit Contractors. All right, they look for all, and they're looking at all Medicare fee-for-service claims. They're looking specifically, and don't get fooled by this, they're looking specifically for incorrect payments, non-covered services, duplicate services, and medical necessity. So just by virtue of their name, Recovery Audit, they're looking to recoup any money that they think that should never have been paid for one of these reasons. All right? Now, they can go back 3 years in time to look at charts, things that, people that may have even expired, people who are much better and you've never had them again. You had them one cert period 2 years ago, and then they're gone, but they can go back 3 years time. It's an ongoing process, especially if problems are found initially, all right? And they are kind of like a hands-out kind of thing, that this is what they are. They're paid to recover money, so they get paid based on what they recover. So very rarely do they go in to a facility, hospital, SNF, whatever, and not find anything, because that means they've done all that work and they're not going to get paid. They get paid strictly on what they are able to recover. The next ones are the ZPIC. ZPIC, of all of them, is probably the one that you probably need to be most concerned about, because their primary focus is on detecting and preventing Medicare fraud and abuse. There are 7 jurisdictions around the country. They look at all healthcare providers. They compare data from Medicare and Medicaid. And for them, and just know that RAC, ZPIC, intermediaries, they can refer from one to the other. For instance, ZPIC is looking on fraud and abuse, but they're looking at what's going on right now. And if it's fraud and abuse, then they can certainly elevate this up to a criminal thing. So you don't ever want that to happen. But I just want you to know what the different ones are in case you hear these initials and you don't know what they really are. And the RHHI is your regional home health intermediary per regions, which is the ones that, and I focused on the ones that we talked about in the beginning: Palmetto, GBA, CGS, and then NGS. All right, they are subject to do probe or focus audits. So probe is like the face-to-face. That was a probe audit. They're looking specifically at, for that particular problem, a problem with face-to-face. And then focus audits, it could be something that's focused on you. Maybe they've gotten a tip about something. They're focused on, maybe it's on length of stay, or therapy that's too high, or your HERC scores are too high. You know, always you're always running a C3, F3, S5, whatever. So they want to make sure that, so they're going to audit so many of your charts just to make sure of that. Focus is that services provided meet requirements for reasonable and necessary visits. All right. Now, they typically do, as opposed to those other two, they typically do prepayment audits. So that's why once you send a final bill, then you get an ADR so they can look at it, review everything before they decide if they're going to pay it. Unlike the others, they can go back to what has already been paid. All right, so documenting medical necessity. Clinical notes should include the following for every discipline. All right, assessment specific to the day of each visit. All right, remember, if it's a wound, I want to know what that wound looks like today, not what it looked like a week ago when I first assessed it. Everything on your visit notes, whether it be the aide, the nurse, the PTA, the OT, doesn't matter. It's the assessment specific to today. Dyspnea, pain, all of that is today. All right, skill services performed at each visit. If every visit note there is not a skill that is performed, then they're going to question whether that visit itself should have even been done. And then that's when they can say, nope, I'm not going to pay this visit. And believe me, when you get an ADR, they look at the visit notes and they'll say, okay, we'll pay visit 1 and 2, but we're not paying 3 and 4. We'll pay 5, but we're not going to pay 6. And those numbers could possibly get you down to 4 visits, which is a LUPA. But also those numbers, visits that they declined, count against your overall denial rate. And you don't want that to happen because that gets publicly reported. Patient's response to treatment rendered. How did that patient respond to what it is that you did? And then the plan for the next visit, because this is very clear. The doctor very well may say, pay PT twice a week for 6 weeks. Okay, he may say that, and the doctor has a right to write that order that way. But if on the 5th week that patient is up and about, and he says, "No, I'm better. I don't need you to come back. I'm going to drive myself to the doctor today. You know, I'm done." Then you don't have a 6th week there. So every visit note has to have a plan for the next visit, because if there's no plan, then there probably should not be a next visit, all right? And again, maybe if you're doing teaching, such as patient giving his own insulin, you've done this today, this is what I did today, this is how the patient responded. Next week, my plan is to have the patient demonstrate what he has learned, but that's a plan, all right? So make sure that all of your notes are showing this, and that's the same thing with the aid. With the aid, it gets very sticky because you know, they all look the same, that they help the patient with the bath. At some point, does it ever get any better? Because remember, home health is never intended to be a lifelong event. We get the patient back to where they were before, or as close to as possible to where they were. So we want to make sure that we are showing progress. What is the patient's response? And if that's not, then something needs to be done, because if what we're doing is not working, then we probably need to revise our plan and let's try something different. And in your notes, these are some of the things that I've put up that when I read notes and I audit charts all the time that I look at. You know, patient sitting up, alert and oriented, talking to her husband, sitting at the breakfast table. That's not really relevant to what, I mean, unless she's never sat up before. But that's not relevant to where you are. Patient with no new complaints, because remember, if I've got one visit note in front of me, I don't know what her old complaints were. So I need to know, just saying no new complaints does not help me if I'm the person reviewing that chart. Wound care performed on what? On her toe, on her head, on her elbow. It has to be specific. And I know some people think, well, I have that on all of my other notes. Well, what if one note gets separated from the others, right? Instructed on disease management and medication teaching. That's so very, very vague. What did you teach them? You know, for a CHF patient who is 90 years old, it is probably not very feasible to say that I taught them everything that they need to know about CHF. We'll continue with the plan of care. So again, too vague. What is the plan of care? Did the plan of, are you talking about the original plan of care or the one that we revised 2 weeks ago because something else wasn't working? All right, so instead you want to be more specific. Pain level since the last visit has decreased from an 8 out of 10 to a 5 out of 10. So at least now I'm showing some progress, all right? Observe patient demonstration of insulin administration. At least if I am an auditor, I know exactly what you did that day, rather than just saying plan of care continued. Patient reports coughing up thick green stuff, all right? Write it as clear as you need to if that's what it is. Wound edges, well approximating, no drainage. And you could then say that wound care was done, but at least we have some idea what it is that you did on that particular day. I can't stress enough how much visit notes count more and more and more, because there was a time when they either paid for an episode of care or they didn't pay for an episode of care. Now they're just picking that episode of care apart and saying, I'm going to pay part of it, but I'm not going to pay the other part of it. All right, so now when you get to the diagnoses, coding to the highest level of specificity, avoiding unspecified codes whenever possible. You know, all of this that just says, well, COPD. And because that may be all that the doctor wrote, it's a lot of times it's as simple as calling the office and saying, can you please look at that Ms. Jones's chart and tell me where he thinks the COPD is from. And you know, when she looks at it, it says emphysema. So that is something a little bit different than just saying COPD, not otherwise specified. You know, UTI, you know, urinary tract infection. Okay, is it the kidney? Is it the bladder? What is it? You know, and again, you don't always get that in the referral that you get, but it's documented somewhere. Keep in mind that the home health codes will not always match the physician codes. I think a lot of agencies get in trouble with this part because physicians' offices, hospitals, urgent cares, they have to code also, and they will use codes. And unfortunately, if it's in a doctor's office or an ER, an urgent care clinic, they use a lot of symptom codes, such as, you know, fever, dysuria, abdominal pain, and then they ended up doing a urinalysis, and it turns out that the patient has UTI. Then it's not necessary to code all of those symptoms. So you want to make sure, and also remember, there are some times where the doctors in the hospital can code an acute, like say for instance, acute CVA, but we can't code that in home care. We have to code the late effects or the sequela of the CVA. So you want to remind your coders, don't just copy those codes from the hospital or from the ER or from the doctor's office. You need to make sure that they're pertinent to what it is we're doing. The condition requiring the most care or the focus of care given should be coded as primary, followed by the other diagnosis for which the agency will be performing interventions. I often tell people, especially when they're not very familiar, they're not very learned on codes, I usually say, if you could only put one diagnosis on an OASIS, what would it be? And unless it's a manifestation that requires another code first, that's usually the reason that's going to be. You know, well, they'll say, well, she's got hypertension, she's got diabetes and COPD and CHF. Okay, but you can only put one of them. Which one is the one that you're going to focus on most? And if the answer is diabetes, then that's usually where your primary. Doesn't always work that way, but most of the time it does. Add your comorbid diagnoses that may affect your plan of care. And I say that because there are a lot of comorbid stuff that may not even affect your plan of care. And I don't want to get into this because, in too much detail because it could take forever. But there are things such as hypothyroidism, hypercholesterol, hyperlipidemia. And I see those filling up your OASIS. And my question is always to the nurse. So if I've got a patient who is hypothyroidism and she's been on Synthroid for 15 years, what are you doing for her? I'm doing medication teaching. But wait, she's been on Synthroid for 15 years. She could probably teach you something. So not every diagnosis that the patient has to be on there. Now, there may be some of you on today that's in hospice. That rule is a little bit different in hospice. Hospice does say that you have to code all of your related and unrelated conditions, but that is not the same rule in home care. You're in home care, you are to code the ones that are going to affect your plan of care. I don't have to do any, she's not having any new symptoms. I don't have to do any teaching because she knows all about it. She has no new medications. Then it's not necessary that I put it in my, and certainly not in my first 6 diagnoses. Be sure that diagnoses are sequenced properly and that each of the top 6 payer diagnoses are addressed in the plan of care. And I say that because if you're going to put it in the first 6, I think a good auditor, surveyor, is looking down in the plan of the body of the plan of care to say, okay, you're saying that this is the 3rd diagnosis in the order of importance, or that's how you sequenced it. What is it that you're doing to address it? And if you can't, if you can't address it, then why are you even putting it on there? So you're actually just giving yourself a little bit more work. All right, Medicare, because Medicare wants to know what you're going to do about these diagnoses, as well as how you're going to keep that patient out of the hospital because of that, and get the patient to an independent or supported independent status by discharge. If they are already independent in taking their Synthroid and knowing when something may not be right, then somebody's done their job. So it doesn't have to be there. Focus on the things that you can address. And again, if it's in hospice, hospice feels like once you have a terminal disease, then most of the things that this patient has is going to somehow contribute to it. Maybe they will stop treatment for some of the things because they are terminal for another reason, but they still could be have an effect on their terminal illness. Show that you have a plan, what the plan is, and how you're going to execute the plan. I'm going to teach them about this medication. And again, another big problem is, let's say that this patient has a new diagnosis of hypothyroidism and the doctor just put them on Synthroid. Then it is appropriate to put it on your plan of care. But is it going to take you 9 weeks to do that? And if you have to reinsert the patient for another reason, do you still need to put it on the next plan of care? Probably not, because I would think that in 9 weeks you would have taught that. And because there comes a time when you either have to decide that the patient has learned this, they're good with it, they're proficient at taking care of it, or they're never going to get there. At which point you have to decide your next plan of action anyway. All right. When you hear people all the time say, query the physician. When the documentation is illegible, conflicting, incomplete, or ambiguous, when clinical indicators of a diagnosis are noted, but no documentation of the condition is available, you can't just decide to code it. You have to find out if they truly do. I mean, people will say all the time, my doctor told me that I have diabetes, or I have high sugar, or I have sugar, or my glucose is high, whatever. Are you to consider that as diabetes? No, you can't. That's something that you have to figure out with the physician. If it's not written by the physician, if it's conflicting, if you're not sure, then you have to make a call, and you need to document that you did verify this diagnosis with the physician. And if enough information is not available to code a specific diagnosis, ask the physician and clinician for more information so that you can code correctly or appropriately. I often use COPD, because COPD, just COPD, that is just, zillions of people have that. But if it's not exacerbated, then why is it the primary reason that you're seeing that? Because a lot of times when the doctor admits a patient for COPD, it's because they were exacerbated. but he may only write COPD on his discharge plan. You need to decide in home care, because you won't get paid if you've got a condition that's stable in some cases, so you want to make sure of that. All right, plan of care specifics. The plan of care must be precise and patient-centered. Avoid cookie-cutter interventions. I tell you, when I'm auditing charts and I can put one plan of care on top of the next cert period, on top of the next cert period, and they look exactly the same, then there's a problem. Because I consider that insanity, doing the same thing over and over again and expecting a different result. If I had this plan of care for 6 weeks or 9 weeks, and I decided that I'm going to recert that patient, obviously something on that plan of care did not work. So chances are I need to rethink what I'm going to do, and then I need to revamp that plan of care. So always, and if you are the person who's reviewing these, you need to make sure they're not just putting the same diagnoses on that plan of care every cert period. For example, instead of writing skilled nurse to teach on cardiac diet, what are you teaching about it? Instead, teach that you're going to teach them the rationale for the cardiac diet, what foods they are allowed to have and what they're not allowed to have. And I realize that your clinical package will give you these things, but you can always adjust those. Those are suggestions, and it makes your life a lot easier. But in some cases, they don't fit every patient, and you need to adjust what's there. Instead of writing, patient will understand the effects of Lasix, right? Nursing to instruct patient on the signs and symptoms of when they've, not had enough, when they may need more Lasix, they're hyperkalemic or hypokalemic, or when to report problems to the health provider. That they're getting swelling, they're feeling really dry, they're just feeling really weak when they stand up. You have to make sure that you're looking at that specifically. Red flag. So this is for the owners, the administrators, the DONs. If the majority of your plan of cares start out with skilled nurse 1 week 9, that needs to stop today, because that is one of the biggest red flags. It is so unrealistic to say that every patient that you admit, especially when they first come out of the hospital, that I'm only going to have to see them once a week for 9 weeks. That is just unrealistic, all right? Frequencies need to be specific, and they should indicate that you're planning to discharge the patient. And who's to say, it doesn't matter what it's for, maybe they're new, a diabetic that just got put on insulin, and that's the reason the doctor wants you to see it. Who's to say that it's going to take you 9 weeks? Why wouldn't it? And I mean, writing it as for twice a week, or if they just came out of the hospital, would probably be a lot better. But who's to say they're not going to get what they need in 8 weeks? All right. So there's no law that says you have to see them for their entire 9 weeks. Focus on what the services are needed, not the availability of care. Upon discharge from a hospital, or when a patient has knowledge deficit, or you have an unstable patient, it is difficult to justify 1 week 9. Because think about this, you've had a patient in the hospital who has been seeing a patient, has had a nurse 24/7 for 5 days. All of a sudden they go home, and you're saying it's okay for us to see them an hour once a week for 9 weeks. That just doesn't make it a whole bunch of sense. And even in the middle of a cert period, maybe you were seeing them once a week for 9 weeks, but in the middle of the cert period, something happened. And then for the next 2 weeks, maybe I need to see them twice a week for a couple of weeks. So that needs to change. And I can't say this enough, front load your visits whenever necessary, or I guess adjust your visits whenever necessary. All right. Documentation to support therapy. Remember that most of the time when you get an order for therapy, that order is usually to justify the evaluation, all right? And the therapist, once they see that patient, they need orders to see that patient beyond the initial visit. They can't go in, if you only have an order that says therapy evaluation, that therapist doesn't get to go in on Monday and then go back on Wednesday and then go back on Friday and then finally call the doctor, because you don't have orders beyond that evaluation. So unless you call after that evaluation. So sometimes it's better to write exactly what it is that they want you to do. Look at what the number of visits projected. Again, do they match what the OASIS is saying? Look at what the patient's current functional status is and what is their patient's plan. You know, obviously if the patient was walking with a cane before they fell, it's unreasonable to think that you're going to make them walk without a cane after therapy. So you need to make sure that that's all matching. That's why the objective tests and measurements are due, you know, every 30 days on these patients, because things change. They don't have to go for a whole cert period. A review of relevant systems, especially if it's a therapy-only case, they are still, this is a whole patient, and you still have to make sure that they are reviewing everything. You cannot just say, I'm only in there for the functional status. What is their progress towards goals? That's our whole point in every one of these patients. Again, getting the patient back to where they were or as close to that as we possibly can. So we have to have a progress to goals. This is where they were, this is where they are today, and this is where I plan to try to get them. It doesn't always work, but that at least is your plan. And then, because sometimes you have to revise your interventions and your goals, because you may realize that they're never going to get there, or they're going to get there sooner than what I thought. So, and in that case, you need to revise your goals. I thought I was going to see him twice a week for 9 weeks. Hey, it's 7 weeks, and he's up walking with a cane. He's good with that. I'm good with that. The doctor's good with that. He's ready to get out, start driving again. That may be where you're going to stop, and it's time to discharge him. Again, no law says you have to go for 9 weeks, because there's a good chance that if you don't do anything more on week 8 and 9 than you did on week 7, then those last 2 weeks of visits will be denied because you didn't do anything. When adding therapies, be sure that your documentation demonstrates why the care is indicated. And then I'm talking to the nurses here, give them guidance on the reasons for the evaluation. So I'm primarily talking about a patient who started out without therapy, and then you decided that something is going on that they now would at least benefit from an evaluation. Then they need to know why, you know. So instead of just saying PT to evaluate and treat, give them some guidance. PT to evaluate and treat due to left hemiparesis with poor understanding of the need to use their walker and increased fall risk. Patient is unsafe walking through his house. Patient tends to fall. Patient is listening to one side. Give them some idea, because then you can, and then that's a lot better, because remember, PT to evaluate and treat, that doesn't tell you what he's going to be treating the patient for. Be sure the therapy plan of care is also comprehensive, specific, and documentation supports the interventions and goals as planned. Can this only be accomplished by a skilled therapist? Because one thing you have to remember, that the Medicare Benefit Policy Manual says that just because something is considered, that just because a skilled person does an intervention doesn't make it itself a skill, all right? So you have to answer, can it only be accomplished by a skilled therapist? Other red flags, previous episodes of care for the same issues. And I am talking about when all 6 of your diagnoses on your plan of care and your plan of care looks the same. Again, cookie cutter. You can put one on top of the other and they look alike, all right? Because that in itself is going to be a red flag on a recert. Compliance concerns, compliance, well, what happened here? Let's see, I went the wrong way. Compliance concerns on the start of care. You got an idea the very first day you got in there that this family is not into this, there's not going to be anybody to do this, the patient is not into it, he's never going to want to learn it. Again, you're in there to make that evaluation. You need to make your decision right then and there whether you can make any difference in this patient. All right, because if that's the kind of patient that you're going to get, and it's going to be very difficult to get rid of them, even though you may not be doing anything new. If you think that there's going to be a compliance issue, you may need to consider whether you really should be admitting this patient. No new diagnoses or issues since the previous OASIS. Okay, so I give you the diagnoses may not change, but if you're going to continue, if you're going to want to recert this patient, there should be some different issues. It could be a different issue, or it could be an issue that you have not yet resolved, but you still think that you can. All right? So, but it cannot be that I'm going to continue to do medication teaching and disease management, forever and ever and ever, because again, that is not going to change. Restarting a patient with the same chronic condition, cert period after cert period, or there's no exacerbation of any old issues. There's no definitive documentation of progress being made. This is the page that makes it sound like I'm very harsh and you're telling me to discharge all my patients. I'm not. But I don't think that this is always the case. I think we're just charting the same thing and my documentation, because remember, whoever's reviewing this chart is not seeing the patient, they're seeing your documentation. It is so very important to get the caregiver involvement early in the episode. Not wait until week 8 to say, okay, Ms. Jones, we're going to be discharging your mom next week, and she's scurrying around trying to figure out who's going to do what. How am I going to get this done? How am I going to get this done? You've got to get that caregiver involved early. And these are the ones that complain because they call the doctor and they say the agency is trying to discharge me or trying to discharge my mom. What am I going to do? And all he's going to do is either call you back and try to convince you to keep her, or he's going to call your competitor down the street. So you want to make sure you get them involved and say, this is what we're going to do. Our plan is to have a therapist in here for a few weeks. And in fact, we're going to have an aide in here for about 4 weeks to kind of help her with her bath and, or help her, or maybe the occupational therapist to try to help her to make it easier, that kind of thing. But if they don't know that early, then they're not expecting it when you get ready to discharge them. Care that's not reasonable and necessary. So remember, not because there's a skill doesn't make it because it's a skilled person that's doing a treatment doesn't make it itself a skill. Numerous cancels or missed visits. When I start looking at OASIS and I see missed visit, I start getting concerned, because then is that patient truly homebound? If I see it, an auditor will see it, and they will start looking for why that patient is missed. And if I look and I see that every time you have a missed visit, it's because of a day that patient had dialysis, then my question to you would be, why are you scheduling the visits on their dialysis days? Why not scheduling it on the opposite days? So you want to be very careful if you are the nurse or if you are the person reviewing those charts. Why are there so many canceled or missed visits? All right. So again, some of this, I'm going to go over some of this kind of really quick because I want to get to the homebound status. And all of this is in Chapter 7 of the Medicare Benefit Policy Manual, Section 20, as I told you about. But as far as what constitutes skill needs, by either the nurse or the therapist. So the service for a skill need, again, it has to be provided by a registered nurse or an LPN under the supervision of a registered nurse. And you have to consider the complexity of it, the condition of the patient, and what accepted standards are. And some skills may be considered skilled based on the complexity alone if it's reasonable and necessary. For instance, IV, IM, insertion of catheters, right? Those are because of the complexity of it. And remember, in some cases, the services that ordinarily is considered unskilled will be considered skilled if the patient condition is such that the service can only be safely and effectively provided by a nurse. But I promise you, the documentation has got to be there. Again, not every skill that's performed by a licensed professional, though, is considered medically necessary for payment. That's why just to go in to do a venipuncture is not considered a skill. All right? So again, become familiar with what the covered services are. Even if a skill is covered, document your efforts to educate the patient and caregiver, especially if the skill will be ongoing. A person who has a colostomy, a permanent colostomy, that's never going to change. So you cannot, it's not reasonable to say that a nurse has to go in there forever. We need to be documenting who is going to give that. A patient who needs insulin, that they have to have insulin and probably for the rest of their life, unless something drastic changes. But it's unreasonable to think that you're going to go in twice a day, every day to give them that insulin. So we need to make sure we're always documenting what it is that we're doing. Observation and assessment. So this is the one I think that probably gets a lot of us in trouble, especially with our research. Observation and assessment of patient condition when only the specialized skills of a medical professional can determine the patient's status. And notice that there are some changes, or they might require more services, meaning that you may need to modify your treatment, you might need to add some different procedures. That's what it is that you're looking for. But here's what the manual says about it. Observation and assessment are reasonable and necessary only until the patient's treatment regimen is stabilized. It must be reasonable, there must be a reasonable potential of a complication or further acute episode. And directly from the manual, services for observation and assessment are covered for 3 weeks or so, as long as there remains a reasonable potential for such a complication or further acute episode. So basically what it's saying is that once you've gotten that patient stabilized and there's nothing else going on with them, and to just say that I'm continuing to do medication management or teaching and disease management really doesn't fly, because it's only covered for 3 more weeks. So I've seen this one used as a denial reason for a lot lately. For the patient where services are extended beyond the 3-week period, the medical record must support the likelihood of a future complication or acute episode. Now, that's not necessarily like a patient with CHF who is frequently in and out of the hospital, because that probably becomes more of management and evaluation, not necessarily just observation and assessment. There are other indications that observation and assessment are reasonable and necessary when it is likely that they will result in changes to the treatment of the patient. ONA, observation and assessment, is not reasonable and necessary when these indicators are part of a long-standing pattern and there is no attempt to change the treatment to resolve them. Patient has no plan to change anything. They're going to continue to eat what they're eating. They're going to continue to do what they're doing. Nothing is going to change. You can't continue to just go in there once a week and take their blood pressure and say, yeah, their blood pressure is good. You know, so if there's nothing going on with it, this is when you need to start looking at what the changes are. All right. Last part is the homebound status. Again, I'm going by the Medicare Benefit Policy Manual. And I don't mean you have to write every word out of this on every visit, but it should be documented on every visit. Are assistive devices or assistance of another person needed to leave home safely is what you're looking at. Don't assume that every patient that was homebound on admission is still homebound. Real quick example of that. You admitted a patient who had a hip replacement, and because of that, and they also had, say, diabetes and hypertension, and because of the hip replacement, they were homebound. Therapy worked with them 8 weeks, says, I'm done. He's up on a cane. He's good with that. The doctor's good with that. Everybody's fine. He thinks that that's as good as we're going to get him. The nurse says, but you know what? His blood pressure's been up a little bit. She can't just decide to reinsert this patient for homebound and say he's homebound because of that, because therapy has already declared him not to be homebound. So don't just assume because he was homebound 8 weeks ago that he's still homebound and therefore I can admit him based on that or reinsert him based on that. Don't assume that every patient, oh, sorry, I keep going above myself. Question again, all frequent absences or missed visits. We know that their patients can go out for some things occasionally, but if she's going out 3 times a week, you know, with her daughter to lunch, to the casino, to Walmart, you need to start questioning where she's going. And one of the best pieces of advice is that I've gotten from someone that says if you have any patient who leaves home at all, you should be documenting on the very next visit. Where did they go? For what reason? How did they tolerate it? Meaning, did they have to get in bed and stay in bed for 2 days after they got back from going to lunch? Or, you know, whatever, or her back hurt so bad, or she was so short of breath they had to go home and get her oxygen before they could even get her home. Things like that. You need to make sure that you're documenting that stuff. Absences must not indicate that the patient has the capacity to obtain health care outside rather than in the residence without a taxing effort. So, for instance, as I mentioned, Patient is going to lunch 3 times a week with her daughter, but the therapist is coming twice a week. You know, could she not go to outpatient therapy twice a week? She's going to lunch 3 times a week. You know, so you need to make sure that you're taking those things into account. And remember, I'm talking Medicare patients here. Some of the other payers allow that. The elderly person who does not leave home due to feebleness or insecurity must still meet all of the Medicare requirements to be homebound. Remember, you got 2 things here. Your patient has to have a skill and they have to be homebound. So they may not ever go anywhere because they're old and they're just decided this is what my life is going to be like now. Doesn't necessarily mean that somebody can't get them into the car to take them to the doctor's office. And, reassessment according to the 2011 regulations. And here I'm talking about, again, reason for assessment number 5. Do I need to reassess this patient when something new has happened? Goals reset if more visits are projected. You know, sometimes things something happens in the middle of an episode that warrants patient is a little bit more short of breath than she was when I was here last week. Maybe I need to see her twice this week instead. I don't mean necessarily a PRN visit. You know, let's give her 2 more visits, 2 visits this week, 2 visits next week, until we're back to where we were before. And then, of course, to reset your goals if those visits are projected. All right, plans for discharge. And remember, every patient needs to have a plan for discharge. We may not ever get there, but that's what home health is about. Again, for the 3rd time I think I've said this, the plan is to get them back to where they were or as close to that as we possibly can. And then, so we need to know that there is a plan. We may have to change things up a few times. Maybe the patient has to be elevated to another level of care, but we at least are going to plan for discharge. If we don't plan for discharge, that patient will never go and never think that anything else is going to be different. I'm going to have a nurse and an aide until I go to glory or whatever, all right? Plans for continued in-home program if discharge is imminent. This is especially with your therapist. You know, this is what we're going to do. Maybe you're never going to go out and work in your garden again, but if we can get you here, this is what we plan to do, and we're going to try and get you to this point at some time during this episode. Patient caregiver documentation and reception of the overall plan of care. If you've got a little elderly person and who primary caregiver is the daughter or the son, you've got to get them involved and they have to be on board with everything. Remember your multidisciplinary case conferences, they are necessary. And conferencing with the physician regarding the new plans. You know, in home and in hospice, the physician is a part of all of their case conferences, but that's not the case with home health. In home health, sometimes your doctor goes 2 cert periods and he couldn't tell you anything about that patient because he didn't even know he still has that patient in home health. That's not the case, but we need to get them, even if it's just a communication to the physician, that this is what's going on. Conferencing with the patient and or the caregiver to say, hey, look, this is what we're doing. It's not working. We're going to have to try this. We've got to get somebody else involved. Reassess your current plan of care because you may need to make revisions to it. Assessing your patient more often obviously comes into play with that same thing. And then early discharge if your goals are met or there's no progression to goals. If you know that you're never going to get there, all right, then we need to start thinking about what else are we going to do. Review every record thoroughly upon discharge before. It should not be a surprise to you that the plan of care, when you get an ADR, should not be a surprise to you that the plan of care was not signed or the visit notes were not signed. It should not be. Every record needs to be QA'd before the discharge. Use a documentation check sheet. I mean, the one that you can, design yourself. Don't assume anything. Remember the old adage, if you didn't chart it, you didn't do it. It's not going to be there. If you can't see it, nobody else is going to see it either. And then, again, last one on that is remember every visit has to stand alone, and your HIPS code can be downcoded because the reviewer decides that you did more visits than what was medically necessary, and they're only going by what you said. All right. Final part is if you get all of this and you still got an ADR, because some of you are still going to get them, assign someone to monitor the DDE system every day. Don't ignore them. Don't think, oh, they get so many, they're not going to notice. Believe me, they're going to notice. Use a check sheet to make sure all the documentation is added. Use a cover, include a copy of the ADR letter. You always want that every time you respond to an ADR. Use a cover sheet and an index page. This, I have to tell you, has probably been the thing that has saved more agencies than anything. Because if you make them go look for stuff, they're going to find other stuff. So use a cover sheet, hand number every page, and if you want them to see where the homebound status is, put it on the index page and say homebound status, page 6. Face-to-face date, page 8. Because if you don't put that, they're going to take that chart apart, and then chances are, even if you had everything else right, they're going to find something that you may have missed. Do not use Post-it notes or highlighters. Post-it note falls off. Highlighters obscure things. Include a clean copy of the plan of care. Everybody knows that if you make a copy of a plan of care, it gets less and less readable. So, make a clean copy of the original one and add that, because if they have to go trying to figure out what it says, they're going to assume that it's not there. Get attestations and addendums from physicians and clinicians when needed. If you know something is not there before you send it, so when you get an ADR, you have 30 days. If you don't send it within 45 days, it's an automatic denial. So you've got all that time to get these things. And if there's something that wasn't there, like the date of the face-to-face, get an addendum from the physician and add it to that. Include a signature log when needed. I don't know what this says down here. I have no idea. They're not going to know whether you scratched it on there or not. So if you have no idea, but this is Dr. John Brown's signature, then add the signature log so that they don't have to come back and question you about it. Assure that everything is signed and dated. Again, if it's a plan of care, if it doesn't say 1 of 3, then all pages have to be signed. If it says 1 of 3, then only the 1 page. If it's a nurse's note, same thing. If you send in the OASIS to the doctor as part of your documentation for homebound status, if it says 1 of 15, then he only has to sign 1, but it has to be signed. Put everything in chronological order, meaning that like the visit notes, you don't want to put them just in, just jumbled order, because then they're going to be trying to piece everything together. And send everything at once and be sure everything is legible. All right? And finally, wait for your response. Now, they give you 30 days to send it, 45 days, automatic denial, but who knows when they're going to get it back to you. Take note of anything, all correspondence, use it as an educational opportunity, whether you pass that or not, whether they paid you for it or not. If they made any notes, you found anything, use that as an educational opportunity, because maybe the auditor for this one passed it, but another one may not. All right? Develop a plan of correction. And I don't necessarily mean whether directed to do so or not. I don't mean like a specific, very formal plan of correction as you do with your COPs, but say, we found X amount of charge where this wasn't there, this is what we need to do about it. And then reinforce during your orientation to include lessons learned. Because if your nurses who have been there for a while are making these issues, or finding these issues, or making these problems, then certainly if you hire some new clinicians, they're going to either learn those bad lessons or they're not going to learn them at all. So make those things part of your orientation to make sure that everybody is going to be on the same page. So I know that was a lot of information, but Rob, we have a few minutes for questions if you have any. And thanks everybody for joining us again.
Yeah, thank you. And thanks for, everyone for joining us. We're going to get to some questions that were submitted here. And I think what I'm going to do is send you a couple via chat here and see what we're able to get through in the little time that we have left here.
And Rob, excuse me, Rob, if I can, I think they are all accompanied by an email address.
Yeah.
If you send those to me after the fact, then I will certainly try to get to them. I'm not saying I'll get to them today, but I will certainly try to get to them individually if we don't have time to answer them all today.
Okay. Great. So Jennifer, I'm going to send you a few of them via chat, and we'll see which ones we can tackle today, and then we can email follow up with the rest, if that sounds okay with you.
All right. So I got the first one, I think. Let me make sure that was the first one. Yep, that is the first one.
Okay.
So it says, what do you mean by do the other follow-up assessment when sending a claim when other discipline like PT was ordered 3 weeks after admission? So this is nothing new. This is an other follow-up, reason for assessment number 5. Several years ago, people knew this as a SCIC assessment. The requirement to bill for a SCIC ended quite a few years ago. The requirement to do another assessment if there was a significant change in condition has not changed. So in this case that I was talking about, if you had a patient who had no need for therapy, PT, in the beginning when the nurse did the assessment, 3 weeks later she fell, bruised her hip, maybe they sent her to the ER and said, oh, it's not broken, send her back home. The doctor says, let's get therapy in there. You're going to have to add therapy in the middle of the episode. But if you just choose to bill therapy at the end, that's going to be a denial because there is nothing in your OASIS that showed that why that patient needed therapy. But if you did an other follow-up assessment, now you can say, this is the point in which her condition changed, and this is the reason that we added therapy. So go into the manual and look at the guidelines on when to file a reason for assessment number 5. Okay?
And Jennifer, I sent you a few over. I sent you over the first few that came in, the first probably 10 that came in. We'll just you can go through as many as we can in the next few minutes if you like, and we can follow up again with email later. And I did want to address one question. Someone asked, the session's been very good. I hope you can. I hope you've taped this, and in fact, we have recorded this. We will send you the link out within the next 24 hours. Go ahead.
Okay.
Jennifer.
All right. Next one. Can patient do their eval one? Can PT do their eval one day as a start of care date, and skilled nurse go out the next day to do the OASIS? Our policy is skilled nurse does the OASIS. If this is a therapy-only case. If this is a therapy-only case, therapy can go the first day because that establishes the start of care date, and the nurse can go on that day or within the next 5 days. But now, if this is a nursing and therapy case, nursing has to open up the case, and she is the one who has to do the actual assessment. All right. So how do you know if the focus of ZPIC is the home health provider or the physician? Well, if it's you will know because of the letter. You will know whether you're the target of a ZPIC by the information that you get in the correspondence. They may want to follow something up, but they're not going to need everything that you have if they're actually trying to ZPIC the physician. So you will know as far as the correspondence that you get. All right. Do we need to get a separate order from the MD for PT frequency and plan of care, even if we include them in the plan of care to be signed by the doctor? Well, first of all, again, remember, most people don't do it this way, but in theory, when you get an order that just says PT to evaluate and treat, there is not an order for you to do what? What does he want you to treat? Does he want you to treat the shoulder, the elbow, the knee, the ankle? What does he want you to treat? So technically, that's why you have to, the therapist, that order is usually just for the evaluation, all right? So in order to get further orders, you're going to have to get, the doctor is certainly going to want to see want to know from the therapist what his evaluation is and what he's recommending. So in that case, the therapist should be calling the doctor and says, this is what I found. I think we should be seeing this patient 3 times a week, hoping maybe in 4 weeks I can get her back to where she needs to be. And then you get further orders. But you cannot just see a patient in a week and start doing whatever, and then a week later get the order for it. That order that you get just for PT to evaluate is just that. Any further orders have to be obtained before you start treatment. All right. Do you know if there are targeted HIPS codes for Medicare ADRs? Every intermediary, Palmetto, CGS, NGS, if you go to their homepage and click on medical reviews, they will tell you, because I looked at them again this morning, they will tell you what their current focus is, what it is that they're looking at right now. Some of them are looking at HIPS codes. Some are looking at visits with more than 18 therapy visits. But the individual, wherever you are, look at your intermediary and go to medical reviews, and it will tell you what their focus is right now.
And that's all we have time for now. We've just hit the bottom of the hour, and we will submit the, Jennifer, I'll send you the rest of the questions, and appreciate your willingness to check those out and get back to the folks. Wanted to thank Jennifer from PPS Plus. Very excited to have this presentation today. Based on the feedback, I think it was a very, very informative webinar. And this webinar was recorded. Everyone will be getting a link to that very shortly.